This is our final lecture in the series on nerves of the lower limb. In our first two lectures, we covered some of the larger, more anatomically and clinically important nerves, the femoral, sciatic, fibular, peroneal, and tibial nerves. In this lecture, we're going to talk about some smaller nerves, but which have particular clinical significance. Our first case is a 58-year-old female who presents to the emergency department 2 weeks after being discharged from hospital following a radical hysterectomy and pelvic clearance procedure. She has a numbness over the inner thigh and weakness of adduction of the left hip. Pause the video, see if you can figure out which nerve is involved, the anatomy of that nerve, the motor and sensory supply, and the clinical features of a nerve injury. This is the obturator nerve. So the obturator nerve is formed from branches of the second to fourth lumbar roots in the lumbosacral plexus. It runs down the lateral wall of the pelvis and exits through the obturator canal. The nerve supplies the medial compartment of the thigh, including obturator externus and the adductors brevis longus and magnus. It also supplies the medial upper thigh. This nerve can be injured during pelvic or abdominal surgery because of its exposure on the pelvic floor, on pelvic wall, and can sometimes be injured in pubic ramus or other pelvic fractures. The clinical features will include numbness over the upper inner thigh and weakness of hip adduction. Here's another case. A 46-year-old obese diabetic patient, male, who presents with burning down the outer aspect of his thigh, but there is no motor weakness on examination. Pause the video and see if you can remember which nerve we're talking about here, and also what is the cause of this clinical syndrome. So this is a condition called meralgia paresthetica. It occurs because of compression of the lateral femoral cutaneous nerve of the thigh. This nerve passes into the thigh deep to the lateral extremity of the inguinal ligament. So its attachment to the anterior superior iliac spine, this nerve runs just deep to that. In patients who are obese, the nerve can be compressed because of pressure on the inguinal ligament, and this leads to a burning sensation down the lateral thigh. It's also seen in some cases of neuropathy, for example, in diabetic neuropathy. And then finally, we've got a 24-year-old amateur cyclist who comes to the emergency department complaining of numbness on the groin after a 3-hour cycle ride to Charlottesville. And this is really a case of pudendal nerve injury. The pudendal nerve is formed from branches of the second, third, and fourth sacral nerve roots. It passes below the piriformis muscle, between the piriformis and the I can't remember the name of the other muscle, but then runs in the pudendal canal, which skirts the inferior border of the ischial tuberosity. And in that area, it can be injured in obstetric manipulation. So, for example, with the use of forceps in cyclists on long cycle rides. And that's also an area in which the nerve can be anesthetized, and the anesthetization of this nerve will cause numbness to the labia in women and the scrotum in men. It also supplies the glans penis and the clitoris, the ischiocavernosus and bulbospongiosus muscles, and the rectal sphincter. So patients who have injuries to this nerve, apart from numbness in the perineal area, may also have sexual dysfunction, and very rarely can have fecal incontinence or urinary incontinence, but that's unusual. Okay, so those were just some smaller but clinically significant nerves in the lower limb. I hope you found this series of talks useful. If you have any questions, you can bring them up in class. If not, we will see you in class. I hope you found this interesting. Again, thank you for listening.